Just to let you know, those of you I haven't met before, I'm the district anaesthetist from Gungu. My name is David Bishop, and I've got a special interest in anaesthesia in district hospital settings. Essentially, this is going to form part of a series of talks. Today, we're doing the simple obstetric GA, but these are some of the topics that I've considered giving next year, and we're going to run a program from February to November, and pretty much do a bit of a deeper dive into some of what we'll cover today. I can't cover a GA in half an hour, so we're going to go quite broadly over it today, and then we'll take some of the aspects of each of the components of the anesthetic and cover those in detail over the year. But please send suggestions. I'm really comfortable with doing any topic if you give me a bit of warning. So just flood me with suggestions about what people want to hear about. And the format is essentially going to be a 20 to 30 minute talk that I'll give, and then discussion for as long as you want it. Probably allowing people to leave around 8:30, but anyone who wants to stay on will stay on as well. Lots of people have been asking me about CPD points. This will be accredited from next year, and I've put in an application for this meeting. So if you're registered and you've put your MP number there and your email address, I will send you a certificate for this meeting if they give me the accreditation, which they've said they will. I'm not sure what to do about rooms where there are a bunch of you sitting listening, and I'm going to find out from the CPD guys, because I think I have to generate some other sort of register. Okay, so we're going to be looking at a district obstetric GA today. I'm not going to be giving you the best method or the most elegant method, but the simplest method. And there are people on this listening today that really can anesthetize very well, and they are very welcome to deviate. But I want you to start as simple as you can, and I'm aiming at the occasional anesthetist here, not at DA level, which is actually a different way of doing this. And I'm going to suggest you come up with one approach, and it's always the same drugs, the same ventilator settings, and you do the same thing every single time. And then as you get more comfortable, you layer your anesthetic and you start adjusting to the situation. Just some resources that I really think are worth looking at. If you go to YouTube and you put in the PMB way anesthesia, a bunch of videos will come up. And I'm going to refer to some of these as we go along. But there's an anesthetic machine check by a guy called Garth Horston, who worked at Madhuleni for a while and is now a specialist anesthetist. And that's had over 73,000 views. People use these things just to remind yourself how to do these things. The basic GA, that's Andrew Levy. It's a system that he's come up using mnemonics. It's worth a look at. And you just got to put into YouTube the PMB way anesthesia, and these things will come up. I can send the links as well if you'd like them. And 3 others that are worth looking at: the emergency drugs, how to draw them up, how to check an airway trolley, and then the obstetric spinal, which I mentioned when we did the last talk a month ago. And these things they're quick. You watch a thing for 5 minutes or 10 minutes, and they'll give you the background. So a general anesthetic in concept is actually a very simple thing. You prepare and position your patient on the table, then you induce, intubate, and ventilate the patient. You maintain the anesthetic, and then you go through the emergency and you extubate the patient. It's really not a complex concept to get into your head. This is the step, I think, that everybody gets nervous about. You're happy to position patients. Once the patient's ventilated, things go all right, and waking patients up is all right. But this step is what really makes people's pulses go up. And what I want to encourage you to do is find ways to practice the things that scare you. So inducing patients is easy, but intubating patients, people don't get enough practice on, and setting and using a ventilator. And there are actually lots of ways to practice these things. Intubations can be practiced on mannequins. When you have resuscitations in the hospital, even when they are futile, make sure that you've intubated the patient. You can find friends in anesthetic departments. You can do InReach, go to the hospitals. Certainly in Maritzburg, we're happy to do this. You come to us for 2 weeks, you do a lot of GAs, and then you have a skill set. And in general, having 1 or 2 people within your hospital that are particularly good at these things, so that they can come stand next to you when you're doing this if you're learning. And I would encourage the anesthetic leads at each hospital, which in Caesarean is now a mandatory thing that someone is appointed that you make sure that this skill set you have. For ventilation, you can put a false lung on a ventilator. You put a bag on a ventilator, whether it's the anesthetic machine or a ventilator that you've got, and you can set it. and practice setting that up so that it's not the first time you do it when you anesthetize a patient. The next thing that you really just have to do, and I know this is tedious, but you have to prepare as well as you can, and that means knowing your theatre. There really is no substitute for somebody knowing what's in that theatre. And again, probably you need a lead anesthetic medical officer, because when you need something urgently, it must come fast. And that lead anesthetic medical officer should take control of what's in that theatre. The list of what you need in there is on the ESMOE guidelines. Again, I'm very happy to distribute these. And if you just have the things that are on the ESMOE essential equipment list, you've got a very good start to a well set up theatre. But there's certain things that if I walk into a theatre, even if I know where everything is, that I will always check. One of them is there an ambu bag in the theatre? And this is absolutely critical. When your machine fails or your circuit leaks or you can't find a leak, you switch to an ambu bag and all the emergency just went away. So find it and check it before you use it. Sometimes you think it's there, but so take that mask off, occlude the end and squeeze the bag, make sure you can generate pressure. Having an oxygen cylinder in theatre is very, very useful. It's difficult to do a GA without oxygen. And all your district hospitals, almost everyone in the country, is run off a manifold cylinder oxygen supply. So you've got a bunch of cylinders that are in a row that are going into your pipeline. But you don't know if you've got COVID patients in the ward that are chewing up your oxygen, or the peds ward's using them, and those cylinders can run out. There are systems that can fail. And having a cylinder in your theatre that's got some oxygen in it is a very good backup. And then the third one that I always look for is suction. When you need suction, there is nothing else that will do the job that suction does. So if a patient has vomited and is aspirating, if you don't have suction, it becomes a very, very desperate situation. So check the suction before you start, and you need a yanker on the end of it. It's difficult to do it with just a tube. So these are things that I never ever forget to do. They've got to become your reflexes every single time you go into theatre. So we'll put something in the way here. The emergency trolley. Again, it's a thing that feels boring, but you just have to get organized. You have to know what's on that trolley. And stocking it and checking it needs to become something that somebody's doing. And it's best if you give this responsibility to someone. I normally find a person that has either wears a moon bag to work or has highlighters on them. People with highlighters are very good at this. You need people that are organized. I suggest you get the ESMOE guidelines again and you display these drugs doses on the wall. And again, you shouldn't be carrying these doses around your head necessarily. Put them on the wall, laminate these things and put them up so that you don't have to remember them. You can just check every single time. Try and reduce how much you have to think in an anesthetic so that you can concentrate on the anesthetic. So display these things or carry the doses with you. And then just to remind you, there is a video on how to prepare your emergency drugs. I'm not going to go into it in detail now because of time constraints, but we can do a deeper dive on these in a separate talk. Know where your emergency drugs are, and certainly you must know where adrenaline and atropine are as a minimum. Whether or not you're going to draw them up depends on a little bit on your hospital supply and how much help you have in the room. I'd like to try and use a poll because I'm interested in seeing whether we can make this work. So I'm going to ask you now, hang on, this is the wrong poll. Let me get this one. I'd like to know what induction agents you have available in your hospital, and you can click all the ones that are relevant to you. And if you can just click now and tell me what you've got, whether, I don't know if that's appearing, whether you've got propofol, ketamine, etomidate, thiopentane, and midazolam. I want to get some idea for what you guys are using before we go into the next section. All right, that's working well. I realize that people with lots of people in the room may not be able to, they'll only get one vote, but okay, that's useful. And I'm going to end that poll now. And it seems to me that 70% of people have propofol, 95% ketamine, about 40% etomidate, and 80% midazolam, and no one has thiopentone, which used to be the go-to drug. All right, I'm going to end that poll now. I think I can show you that result. So that's sort of what you guys have got out there. I'm going to speak mainly to ketamine and propofol this morning. I think, and I'm glad that seems to be what you guys have. Propofol, we've got a bit of a national shortage at the moment. Okay, so moving on to the airway trolley. Again, you just have to know how to set this up. And again, it's better if one person is checking this because they'll know what's supposed to be on there. But before you start the anesthetic, you need to check this. Once again, this airway trolley check is done on the PMB way. It's a 5-minute video, and there's five metals and 5 plastics. But just to make the point, you need a working laryngoscope. And we always talk about needing, if anybody's done an intubation when your laryngoscope has failed, now the patient is induced and paralyzed and your laryngoscope fails, you get a little desperate. You can't really get your phone out and start putting a torch down the airway and trying to put a tube in. So it's really worth doing these things, because most of anesthetics is hoping for the best but preparing for the worst. And so you just need to have these backups. You need different size endotracheal tubes, especially smaller ones, Guedel airways. And in particular, you need a supraglottic airway device when you're doing an obstetric GA, which is an LMA or a ProSeal or an iGel, whatever you've got, usually a size 3. And you must have this on your trolley. It's absolutely critical, as we'll come to just now. So check for that in particular. You need to know how to do a machine check. And again, at DA level, there are literally tens of things that you need to look at. But you've got to get used to at least checking the things that really matter. So this machine's got lots of problems. There isn't a circuit on a machine. This is surprisingly easy to miss. You think you've got a circuit on and somebody takes it off the machine before you start. Check that there's a circuit on the machine. Check that the soda lime isn't the wrong color. The soda lime is exhausted and it's not going to work at all. Check that the machine is on. Again, it's something that trips people up for some reason. Make sure that you've got volatile anesthetic on your machine and that it's seated well. That's one of the sources of big leaks. Big leaks tend to come from circuits being detached, soda limes that is not fitted right, and vaporizers that are not seated well. Those are the 3 main causes of big leaks on machines. Check that you've got gas supply and turn those things up, the rotameters. Make sure that they work. And finally, that circle that I've drawn there is around the APL valve. Make sure you know how to work this thing before you start the anesthetic. Also trips people up. So dial it down to generate pressure, close the circuit against your hand and see that you can generate pressure. I don't mind anything else in that machine not working as long as I'm able to generate pressure when I squeeze that bag, then I know I'm going to be able to ventilate someone. It's the most important thing that I check on an anesthetic machine. And I will do that between every single anesthetic before I start an anesthetic, because things change. People fiddle with your machine while you're not aware. So know your patient. We talked last time about examining your patient. If you anesthetize a patient and you haven't examined the patient, you've really missed the ball. And missed the boat, dropped the ball. I'm mixing my metaphors. Firstly, make sure you've listened to the heart. Put the stethoscope on the heart and listen to the heart sounds. Secondly, check the airway. And it's one of those skills you need to check the airway on every single patient. Just get used to doing that as an examination, and you'll develop a knack for knowing when you're going to get into trouble. And finally, check the HB. And then use your monitors. For some reason, we don't always put these all on. ECG, NIBP, SATS probe, every single patient. It's absolutely critical. For the GA, you're going to want capnography as well. So those are basics, but do the basics well. And then before you put the patient to sleep, think before you start. The first thing is, what is the indication for the general anesthetic? Sometimes this just gives you a clue as to the fact that you might get into trouble. Cord prolapse, when you bring them through, you're rushing, you're going to forget things. When you have an abruptio and you're doing the anesthetic, maybe this patient's going to bleed and you need to set up. What is the heart rate and the systolic blood pressure? When that heart rate is higher than the systolic blood pressure, that means that we call that, well, it's like using the shock index. But when that heart rate climbs above the systolic blood pressure, your patient is in trouble. There's a hemodynamic compromise, which brings me to the third point. Does the patient look sick? Are they septic? Do they feel like a healthy patient or a sick patient? Because sick patients get different doses to well patients. Healthy patients pretty much can get an amp of whichever drug you've chosen to go to sleep with. It's pretty much designed for a 70-kilogram person and you'll probably be fine. But if you give a whole amp of propofol to a sick patient, they will arrest when you put them to sleep. So sick patients get half a dose or a quarter dose, and you need to titrate to how sick the patient is. So it's worth just stopping and saying, am I dealing with a sick patient before I start? Particularly true in ruptured ectopics. And then again, have you looked at the airway? Now, when you look at an airway, this is the ESMO-E suggestion. It's not a very user-friendly thing. I'm going to do a whole talk on airway evaluation. If I can just point you to a couple of things. You should think, am I going to be able to mask ventilate this patient? There's a scoring system for that, which I'm not going to get into. You need to look at, will I be able to intubate the patient? And the ones that I think there's actually 11 in the American guidelines. The ones that I particularly always check are do a Mallampati score up in the top right there. The reason you do that is because then you're also checking that the patient can open their mouth, which is something that we sometimes forget. And you don't want to put a patient to sleep who's got a wired jaw. So check the Mallampati score. Check the distance between the chin and the thyroid. That's called the thyromental distance. You want a nice long thyromental distance. When it's short, and I'll show you a picture just now, that means the airway is going to be anterior and you're going to struggle. It's probably the most important thing I look on when I'm doing a laryngoscopy is there a long distance from the chin to the thyroid cartilage? And you want 5 or 6 centimeters, but the longer the better. And you want to position patients so you can see that length. So evaluate the airway before you start. And then I just want to remind you that not every patient you're doing a GA on in the district hospital should be done there. Ruptured ectopics don't get referred. You have to do them on site. That's going to be the topic. We'll do a topic on that another time. Very obese patients are supposed to be referred, and I know you can't get these patients out of the district hospital, but just bear in mind that the obese patients coming with lots of risks, especially the airway. So think, are we doing this in the right setting, and do we have options? And then when you assess a patient as having a difficult airway, sometimes the right move is to refer that patient, even if it's urgent, because if you put the patient to sleep and you can't intubate them or ventilate them, then you haven't done them any favors. And there you want to phone a friend. You can actually send them pictures. You can have a discussion. So make friends with anesthetists that are close to you so that you can refer these patients. And then in the ESMO-E guidelines, there's a protocol for Caesarean section under general anesthesia. And this thing is actually quite good. It takes you through a stepwise, this is how you go about doing it. So display and laminate these things in your theatre and literally just check off as you go. There's a few things that I suggest you do when you start. Make sure you've assessed fluid status. If you're not sure, give a bolus. The only one that I think I would be wary of is the pre-eclamptic or the eclamptic patient. Everyone else can do with a bolus, because when you put patients to sleep that are hypovolemic, they tend to drop their blood pressures very, very quickly and even arrest. Get good IVI access. Use checklists. Again, the person with the highlighters can sort these out, but a checklist and the WHO checklist are invaluable things, and they change outcomes. They really they help people do better. Set your NRBP at 3 minutes. Position the patient. I'm going to show you a picture now. Take time on positioning. They still need a wedge for a Caesarean section. I know there's a lot of controversy about this, but in general, put the wedge in. Pre-oxygenate for 3 to 5 minutes. Not longer and not shorter. Longer actually doesn't help patients, and shorter, you haven't got enough in. So 3 to 5 minutes of 100% if you're in a district hospital. Decide if you're going to use cricoid, can the person who's assisting you do cricoid? It's not a good idea to give the cricoid pressure tat after the patient's asleep. And again, you have to ask. If you put the patient to sleep and then the person with you says, I don't know how to do cricoid, it's actually the fault of the person who put the patient to sleep. So just check with your team. Check before you put the patient to sleep, do you have that supraglottic airway device, which is going to be so critical when you fail. Confirm your tube, that is, confirm it clinically. Check that the chest moves when you bag the patient. Check on capnography. Use at least 40% oxygen. In a district hospital, we'll go lower in regional and tertiaries, but you should use 40% oxygen. That's the standard ESMO-E wants. and then ventilate the patient, which I'll come to. When you position the patient, this is a patient who is potentially a difficult airway and is not actually positioned very well. Particularly, think about how you would get a laryngoscope in there. You might not be able to get a long-handled laryngoscope in there, so you may need a short-handled laryngoscope. When you need a short-handled laryngoscope, when the long one doesn't work, you will panic. It's very, very difficult to when the front of the laryngoscope is obstructed by, it's usually a large-breasted person, but positioning also does it. This is how you position a patient when you think they've got a difficult airway. So the ear to sternal notch, you must see that line. Get their head elevation up, ramp them if you need. And you can see that thyromental distance now is actually very good. This is going to be an easy airway, but it's only easy because you've positioned well. And if you forget to position well, you'll see in all the airway algorithms, it's when you fail, position better. But you should have positioned right from the start. And especially if you're struggling, spend time getting this airway position right. You don't want to be doing this mid-intubation. So this is a thing that you really want to do well. The Airway Algorithm, this is now taken from the Difficult Airway Society algorithm. It's a nice algorithm. I like it. It's specific for obstetrics, this one. And there are just 2 points I want to bring out to you that are slightly different from what you might think. The first is that when you do a rapid sequence induction, you give the induction agent, and then you're waiting for your succinylmethonium to work, and that's 30 seconds. You are required to consider face mask ventilation with a pressure of less than 20 centimeters of water. So you dial that APL valve up to 15 or 20, and while you're waiting for the sucks to work, bag the patient. Now, there are some traditional anesthetists who don't like this. You sometimes get a bit of stick, but I've adopted this in my practice and I love it. What it does is it tells you can ventilate the patient. It also doesn't let the patient desaturate, so you lose that panic when you start intubating the patient. So I do this in every single GA Caesar that I do, except where there might be some contraindication, but there's almost never that contraindication. So I advise, it's called gentilation, and the only proviso is that you mustn't generate pressures of more than 20. So you have to do it with low pressures, and then there's no aspiration risk because you won't insufflate the stomach. I know that's going to cause controversy, but I suggest you do it in every single patient. It revolutionized how few patients drop their SATs. At Edendale Hospital, a regional hospital, 1 in 6 patients drops their SATs below 90%. We did a series of almost 400 patients, and it's about 16%. 1 in 6 patients will drop their SATs below 90, and that's with guys who do this every single day. So use every advantage that you've got. The second point that I want to make is have your supraglottic airway device ready, maximum 2 attempts. If you're failing, stop trying to intubate and put in a supraglottic airway device. The goal here is ventilation, not intubation. You're trying to move oxygen in those lungs, not get a tube in, and you must do that through any way that you can. You can even do a Caesar with mask ventilation if you have to. If you persist with trying to get that intubation when you're failing, sometimes that's the problem. So you must give up and put in a supraglottic airway device. And the failed intubation drill is in the ESMOE guidelines as well. It's also not the most user-friendly, but call for help early. Ideally, call for that help before you put patients to sleep if you're a beginner. Cricoid pressure, you use it, but you can release it when you've failed. Get the position right, use a jaw thrust, stick in an oropharyngeal airway, mask ventilate. If you can ventilate, the emergency's over, take your time. If you can't, get the LMA in. If that doesn't work, you're moving to surgical airway, which is a cricothyroidotomy. And then potentially, if you manage to ventilate the patient and the patient's not bleeding out, you can wake the patient up and refer the patient. So remember that. But keep these things on the wall because you will not remember this when the SATs are dropping. It's difficult. Just for the ventilator, get to know your specific ventilator of your specific machine. This is a Fabius. Practice with a test lung before you start. So go in there when there's no rush. Set up the ventilator. Pick one mode you like. I would suggest volume control. This is not my favorite mode, but it's the easiest one to learn. So I would suggest you pick numbers that you always set the ventilator in, something like a tidal volume of 400, a respiratory rate of 12, the PEEP at 5, oxygen at least 40%. And if you've got a synchronized mode, use the synchronized mode. I actually use higher PEEPs than this, and I'll adjust that ventilation. But just when you set it in the beginning, and then you switch over to ventilation and adjust as you go. Now, when you actually put patients to sleep, this is pretty much big amp, little amp, tube, turn on the gas, or give them a bit of ketamine, and then switch off the gas and pull the tube out. That's how simple it can be. So if we move into actual drugs, you might give ketamine and sucks, or propofol and sucks. You maintain with isoflurane. You give some morphine when the baby's out, and then you switch off at the end and take out the tube. And that's not too difficult. That might be ketamine 2 milligrams per kilogram and sucks 1 milligram per kilogram. Set your isoflurane at about 0.8. You can switch this up and down as you go, but when I turn it on to about 0.8. Or if you're out of gas and you're using ketamine, it's 1 milligram per kilogram. Just remember your patients won't lie still with just ketamine anesthetic. You might have to add a much relaxer. And then try and keep the heart rate under 120, the blood pressure over 90, and the HB over 7. This article, which Simon Leroux and myself published earlier this year, is how to do anesthesia for ruptured ectopic pregnancy at district level. And we made this, which is how to do the anesthetic for it. Now, it may look complex, but basically it takes you through the steps that you need, what you need before you start, and then it takes you through induction, maintenance, and emergence. And it's literally saying pick an induction agent, pick something to paralyze with, intubate, pick something to maintain with, give some analgesia, and at the end, reverse if you've used something like rocuronium, but if you've used sucks, you don't have to, wake the patient up and extubate. And it's a nice thing to put on your wall, I think, just to remind yourself of the different steps as you go. I want to ask I'm going to do one more poll, and that is on the timing of draping. I'd like to hear, when you intubate, do you drape the patient first, get the patient ready, clean, have your surgeon scrubbed, and then intubate? Or are you currently intubating and then draping? I just want to know your practice. There's actually not a right answer to this, but I'm very interested in what everybody's doing. I'll tell you what I think the right answer is now, but there's a lot of debate about this. Okay, so about 2/3 of you are intubating first and then draping, and about 1/3 are cleaning and draping first and then intubating. And all I really want to say on this issue, because we've debated this one backwards and forwards, is that if you're a beginner, if this is something that scares you, if when you give the induction agents, your heart rate goes through the roof, intubate first and then clean and drape, because you will get access to the airway and it's much easier. Once you've draped and that screen's in the way, it's a more difficult intubation. So if you're in the camp that wants to clean and drape first, please be an experienced anesthetist, be someone who knows how to handle an airway. I sometimes do that in anesthetics. But if I'm going to tell a beginner what to do, I'm going to say just set up and intubate first, because it just takes a lot of the panic away from it. The baby will have a bit more gas in it, in the baby by the time you get the baby out, but they'll have less induction agent. So it's the baby. In terms of the baby, you're going to need someone to help with that baby anyway, because it's a GA. I would advise doing the intubate first. Okay, I'm going to close that poll. Almost done. I want to just mention a couple of common complications. The one is movement. If a patient moves under anesthetic, the treatment of that movement is not muscle relaxant. It's a common reflex because you just want to stop the patient moving, but remember, movement might mean awareness. And there's really a couple of things you can do. Movement implies that the stimulation, the peripheral stimulation, is higher than the central sedation. So you can either turn your gas up, or you can treat the stimulation, and this is what I suggest. So if the patient starts to move, give them something that takes away the pain. So give them fentanyl. Give them a quick-acting opiate like fentanyl. It'll last 20 to 30 minutes, I would just give them 100 mics. And if they don't stop moving, then increase the volatile. Try to stop the surgery while you sort out the movement, but don't treat it primarily with a muscle relaxant. I have seen this before where people say every time the patient moves, give them a bit of SUPS or rocuronium. That patient might be awake. And they may not remember it afterwards, but they may well have been awake. The second point I want to make is around extubation. Remember that the complication rate at intubation, complications being failed intubation or bronchospasm or aspiration, intubation rate is 4%. Extubation, the complication rate is 12%. It's 3 times higher. But think about when you intubate, you're surrounded by staff, and when you extubate, there's often no one around or paying attention. So pay attention to this phase. And if you are, especially if you're a beginner, the patient must be wide awake. If you're not sure, wait. A lot of the complications come because we pull those tubes too early. And I often tell someone that if they're alone and they're scared, have the patient awake enough that they could write you a letter saying, please, would you take this tube out? Wide awake. It's not nice for patients, but it prevents a lot of the complications, because if you take it out a little bit early and then they go into laryngospasm, you are not set up for this. And finally, just think about patients under GA bleeding. They often have a bit of atony because the gas prevents the uterus contracting. Often the indication is a scary indication where they're bleeding. And so have something like adrenaline drawn up. I've got a simple recipe, and I'm going to give a talk on these sorts of things another time. But if you've got a separate line, put 4 milligrams into 200 mils and start it at 10 mils an hour, run that through something like an IVAC, or you can put it in a 50 mil syringe, 1 milligram in a 50 mil syringe. If you're on the same line, you're in that sort of situation, put an amp into a liter and then just titrate to effect. And remember, if they're bleeding, they need enough fluids as well. Almost done. Value the recovery period. I just want to remind people, don't send the patients out too quickly. So really make sure they're well before they go. Once they go out, it's hard to check on them. And this again is in the ESMO guidelines. Finally, second to last slide. This is from Maya Angelou, and just an American poet. Do the best you can until you know better. And then when you know better, do better. So you're going to make a lot of mistakes when you do GAs, and to be honest, it's fine. You have to make mistakes to get better. So, and then once you know better, do better. So this is just a call really to prepare well and think well. And then when there's a mistake or a complication, get a hold of me or get hold of a friend and say, what could we have done better? And then change your practice. So the next time around, you get better at this. The last slide I always finish with is phone a friend. Get to know your anaesthetists at your local hospitals, because they really can help you. And if you can't find a friend, if the anaesthetists near you are either not helpful or they just don't have a department, then like I've said before, I will be your friend. There's my phone number, there's my email address, and you can even just refer patients to me on Vula. That will be under Edendale Hospital, and we'll just have a chat about the patient if you want to use that mechanism. And I'm very happy for you to get hold of me. I may not answer my phone always, but you'll always get an answer if you email me eventually within a few days. All right, so that's all we're going to cover for now. I'm sorry, that was a 34